Yeah, it's coming.
So, sir, we are live now.
Yeah.
Okay, so we start. So, good afternoon, all dignitaries. On behalf of Corona Remedies, I would like to welcome each one of you for this Nerve Nirman meet. Today's topic is nerve injury post-COVID-19. Today, it is our privilege to have amongst us Dr. Hasnain Kesar as a speaker of this session. He is highly qualified and eminent speaker. He is basically from Patna. Talking about his academic qualification, doctor is MBBS from Darbhanga. Then he has done MD medicine from Delhi University and DNB nephrologist from New Delhi. Doctor has also done post graduate diploma in diabetes management from University of London, UK. Postgraduate diploma in cardiology from John Hopkins University, USA and Royal College of Physicians, London. Doctor has done fellowship in endoscopy from Jaswant Rai Hospital, Meerut, UP. Doctor is also pursuing fellowship in endoscopy from Endocrine Society of America. Doctor was ex-government medical officer for 13 years past his MBBS. Doctor's key interests are nephrology, endocrinology, and endoscopy. So doctor is basically consultant physician and nephrologist who is amongst us. I wish all the participants the very best, and I'm sure that the CME will definitely be an enriching experience for all of us. So with this, I welcome Dr. Hasnain Kesar to begin the session. Sir, over to you.
Thank you very much for giving my introductions to all. Good afternoon, everybody. We know that we are going through a very big pandemic all over the world, and also our India is facing such a big disease and pandemics now. And a lot of our beloveds have lost, and the nation as well as the humanities lost in these pandemics all over the world, including our nations and also my state too. So due to COVID-19 disease, there is a multi-organal damages, including the lungs, including the hearts, including the other parts of the body, as well as the nervous systems also affected due to the COVID-19. So we are just here to discuss the nerve injury after the post-COVID-19. So my presentation here is to how to manage and how to diagnose the nerve injuries due to the COVID-19, those who survived. Definitely, in our day-to-day practices, these cases are commonly come across. And my personal experience is here. I have seen more than 1,700 patients of the COVID-19 during these pandemics in the past 1 year. So, nerve injury post-COVID-19 disease. Next. So we have to focus on first. We have to diagnose whether the patient is suffering from the COVID nerve injury other than others injuries or not. It's very simply, we know that the COVID-19 patients are having the symptoms like that, the fever, dry cough, and the fatigues. We all, the consultants, the physicians, as well as the specialists are well aware of that, the symptoms. And the respiratory system is primarily affected in the severe acute respiratory syndromes like coronavirus infection, neurological complications, and affecting both the central and the peripheral nervous systems have been reported there. An observational investigation among the 214 patients with the COVID-19 is reported peripheral nervous system involvement up to the 9% of the peoples. Though this is the data among the 214 patients. No doubt it's a very few numbers, but still we have one practice. Our daily practice, we have seen that the patients are complaining and the difficulty in the smelling. Definitely, it is the symptoms affecting the nervous systems. So it is near about 9% to 10% cases of the COVID suffering to the peripheral nervous system disorders are reported. So as the number of survivor COVID-19 surge, long-term sequelae and the rehabilitation concern related to the neuromuscular pathological conditions are becoming more apparent. Next. So the route to the COVID infection in nervous system is very common. We are commonly hearing that the patients complaining that I have lost my taste, I have lost my smelling. These are all pertaining to the COVID-19 infections affecting the peripheral nervous system. So the COVID viruses are primarily initially affecting the upper respiratory tract, including the pharynx as well as the laryngeal larynx, so nasal cavity too. So and the route of administration is also from the nasal as well as the oral. So coronavirus enter the nervous system directly through the olfactory nerve. Very interesting. Olfactory nerve is the first nerve which is infected by the olfactory by the peripheral nervous system, including also the blood circulation is also the common, because the virus is circulating all over the body and in affecting the different goes to the different part of the body, either from the nervous systems, central nervous system, the peripheral nervous system, as well as the enteric nervous system is also gone there. So, and from where the ACE inhibitors, angiotensin converting enzyme 2 receptor, which is found over the cells, particularly over the lungs, where these receptors are come in contact with the viruses, and they penetrate through that as in the lungs as well as in the brain systems and the peripheral nervous systems. So ACE2 inhibitors in the brain systems. Immune injuries also caused through the immune injury. Our different protective cells are injured by the coronaviruses. So our defense system, including the first line defense systems, are just directly affected by the viruses. And so neurological pathway are also in concern with the involvement there, resulting the neurological disorders. And we are always seeing that the patients complaining initially the loss of taste and smell too. And the COVID-19 infection in the gastrointestinal could be used the enteric nervous system. Definitely when the viruses reach the intestine and they are where the enteric systems are present and the viruses are affected there, enter there and causing the injury to the nervous systems. And sympathetic afferent neurons to the reach the through the enteric systems, they reach the central nervous system via the sympathetic nervous system to the brain. Next. So the most typical neurological feature associated with the COVID-19, the the neurological symptoms typical of the initial and the mild phases, where the headaches, hypo and insomnia. As I had been told you, there is a muscles due to neuromuscular junction affections and the muscle damage with increased CK, LDH, CKM, CKMM. We are sometimes we are just writing the investigations to know the whether the symptom whether muscle damage is occur or not. Nextly, the delirious patients undergo the delirium when the severe infection of the virus and affecting the central nervous system primarily. Then there is a delirium, impaired consciousness, pyramidal signs, as well as ischemic strokes. I have seen the patients which have affected the central nervous system with the multiple vessel injury. Ultimately, patient is suffered from the strokes. And my colleague, which is a neurophysician, who said that patients I come across in my hospital where the triple vessel injury was there in the strokes, and the patients where ultimately patient lost their life. So there is a ischemic stroke is well recommended. Next. So in the what COVID-19 and the nerve damage, the coronavirus can cause nerve damage through the direct infection pathway, blood circulation pathway, as well as the neural pathway, and resulting in the hypoxia, immune injury, ACE2 inhibitors, as well as the other mechanisms are available here. The diagram where they shows that after the infection through the olfactory bulbs, for the nasal affecting the olfactory bulb, reach the viruses, the olfactory bulbs. Then from there, the vagus nerves are affected, and the blood stream is goes. Also, there the central nervous system is gone there. So here, the one thing is very important here: the ACE2 inhibitors, the coronavirus affecting the cells where the ACE inhibitor receptors are present here, which go through from where they are going to the endosomes. From there, the membrane fusion is there, and coating is there. Virus replication by using the defense system over the replication system of the body. They multiply here, and after the multiplying there, they ultimately release into the blood streams. So what happens is that they can enter the nervous system directly through the olfactory nerves, and also enter the nervous system through the blood circulations and neural pathway, resulting in the neurological disorders. Next. So the prolonged hospitalization, as we know, they say that the patients are usually those who are admitted in the hospitals and ICU cares. As they are under the prolonged hospitalization is here. This leads to the peripheral nerve abnormality due to critical illness and polyneuropathy as secondary to the prolonged patient's hospital positionings. So patients are usually lying supine, and so there is a peripheral nerve damage. There's a high chances of damage the patient's positioning due to resulting in the peripheral nervous injury. The differential diagnosis of peripheral nerve injury in setting of COVID-19, including the post-infectious inflammatory neuropathy, prone positioning related to stretch and or the completion injury. Usually the patient sometimes having those who are on the ICU care, if we are not caring, there is a bed source are there. This is the further symptoms of the compression injury, systemic neuropathy, as well as the nerve entrapment secondary to hematoma. There is sometimes hematoma is also, the patches are also there in the bodies. This leads to the hematomas on the body. This is showing the hematoma of the body. All this leads to the peripheral nervous system injury. Next. So these are the differential diagnosis of the different, as we just said in earlier slides. The differential diagnosis of the peripheral nerve injury in the patient with the COVID-19 is inflammatory neuropathy. There's well the prong Turner syndrome. These are Turner syndromes, positional-related peripheral nerve injuries of extremities, as well as positional-related Braxial nerve injuries and distal symmetric neuropathies, and nerve entrapment is there. So these are the findings among the MRI as well as US characteristics. US ultrasonography characteristics are here. In the patient of inflammatory neuropathy, MRIs and ultrasonographies are recommended. These are the imaging modalities which have to be taken under accounts. And this shows the characteristics that inflammatory neuropathies, there is diffuse signal hyperintense of the cauda equina, and the nerve roots and plexus often asymmetrical, usually asymmetrical because it is acquired injury, because it is also mostly, it may be usually the usually not the bilateral, usually the asymmetrical, often asymmetrical nerve enhancement is of acute is there. So ultrasonography, what shows here, thickening of affected nerves, as well patients showing the clinical feature, there is a progressive weakness, falling infections, and acute. Initially, patients are not having such complaints like the progressive weakness. These are usually after of the patient complaining. They come to the opinion with the patients who recover from the COVID-19. They come your clinic and the hospitals. They are complaining. So I'm having the progressive weakness. This shows this definitely. This remarks you. This will trigger you. Definitely, it might be possible the patient is having the peripheral nerve injury, and so we have to undergo the certain investigations and their imaging mortality, and they are having in the mind that a patient might have the inflammatory neuropathy. Turner syndrome, PTS is usually also is there. So there is in MRI is recommended for better evaluation of the muscles, as well as for small nerves not well seen in the MRI. Ultrasonography is recommended here. Signal hyperintense thickening, often of multiple plexus nerves, muscle edema-like signals. This is usually shown by the MRI characteristics, and the USG characteristics there. Hypoechogenicity, thickening of affected nerves, and that's the suprascapular as well as long thoracic nerves are shown here. So sudden and rapid onset of falling infections. If the patients are showing that the patients are having the clinical presentation of sudden and rapid onset, we definitely go through the having the PTS might be there, and so we go for the MRI as well as ultrasonography evaluation for those patients. If the patient's having the weakness, sensory deficits acquired during the hospital's course, and often asymptomatic use of the prone positionings, certainly we have the having the mind there is might be a positional related peripheral nerve injury of extremities, and this here we also go for the MRI as well as for better for the muscles evaluations, and ultrasonography for the dynamic as well as the dynamic imaging of the patients. So signal hyper intensity of the affected nerve with or without muscle edema, like signal of acute and fatty atrophy of the chronic muscles are showing in the MRI finding is there, and there is a hypoechogenicity, thickening of affected nerve with the or without subluxations on the dynamic maneuver, with or without muscle atrophy, and hyperechogenicity of the chronic is present here. So these are the findings of the MRI ultrasonography of the positioning related peripheral nerve injuries extremity. And the next is here, if the patients are complaining having the weakness and sensory deficits acquired during the hospitalized course, often asymptomatic and use of prone positioning. So yeah, there is a position related to brachial plexus injury, and the findings in the MRI is there. There is a hyper intensity of the thickening of upper or lower plexus with or without muscle edema, like signals of acute atrophy as well as chronic is there. So if the chronic is there, if in the ultrasonograph finding hypoechogenicity, thickening of upper or lower plexus with or without muscle atrophy, and hyperechogenicity is done here. If the patient's having the pre-existing polyneuropathy plus comorbidities like the diabetes, uh, as well as acquired polyneuropathy and the myopathy and the critical care illness, show the distal should be in our minds, typically not performed for the diagnostic purpose, and diffuse signal hyperintensity of the nerve with or without multifocal muscles edema like signal fatty atrophy based on the etiology and chronicity should be here. The thickening of the affected nerve with or without multifocal muscle atrophy of the chronic is here noting here. Pre-existing, so these are the MRI and ultrasonography on the patients with having the distal asymmetric polyneuropathy. Nerve impairment might be possible. There is a nerve impairment is here. So if there is a nerve entrapment, MRI ultrasonography shows hyper intense of affected nerves, nerve compression of the altered course due to the muscle affected with or without here. So there is a hypoechonicity thickenings of affected nerves, and the complications noted are the nerve compressions and altered courses due to mass effect or without is noted here. There is a weakness and sensory deficit acquired while undergoing anticoagulation therapy with or without affecting the muscles mass. Next. So we are just having these things in our minds, and we are just differentiating the different diagnoses and through the ultrasonography MRI, and accordingly we treat the patients. This is the imaging in 21 years old. 21, this is a case one, and imaging of a 21 years old man with no past medical history who was diagnosed with coronavirus disease and 19 with the prolonged hospitalized care course for adult respiratory distress syndromes requiring intubations and prone positionings. So during this his hospital course, he developed the left shoulder weakness. Left shoulder weakness with abductions and acquired positional related brachial plexus injury was suspected. The clinically MR neuropathy of brachial was performed, and sagittal section of T2M sampling perfection with the application of optimized contrast using the different flip angle evaluations, especially short time invasions recovery STR image after the contrast enhancement for the vascular compressions demonstrate the signal hyperintensity of the CS and C6 nerves used. These are the arrows which are showing there is a brachial plexus injury under the STR and the space imaging modalities. Next, in the same here, the coronal sections, coronal T2 space STR image after the contrast enhancement for the vascular compression demonstrate a signal hypertensity of the both lateral as well as posterior cord as well as suprascapular nerves. Next. So here the image of in case 2 here, the image in the 45 years old man with a history of the gout and the diabetes mellitus was also admitted for acute inpatients rehabilitations after prolonged hospital course due to corona disease. He noted that new onset numbness in the digit 4 and 5 in the both hands, as well as weakened grips that developed during his hospital course was bound to have a reduced pinpricks sensation on the ulnar sides of the hands and fingers. This diagram shows. Next. Next, please. In the case 3, this is an image in the 66. This is an image of 66 years old woman with history of breast cancer who has prolonged hospital course for corona disease and related respiratory failure requiring intubations and the prone positioning. During her hospital course, she developed moderate to severe right upper extremity weakness with clinical suspicion of prone positioners related peripheral nerve injury. An ultrasonography of the median nerves demonstrate the moderate hyper echogenicity, thickening, and loss of fascicular architecture at the level of the wrist. Next. So ultrasonography of the posterior interosseous nerves, the arrow showing there the hypoechogenicity at the level of the elbow, adjacent superficial branch of the radial nerves. The arrow which are showing here is the normal. But in the US of the bilateral, thinner muscles demonstrate mild atrophy of the right thinner musculature compared with the left. And the US of the bilateral supinator muscles demonstrate the moderate fatty atrophy of the right supinator muscles compared with the left. She was diagnosed with the COVID-19 related polyneuropathy is here. These are the ultrasonography findings of the patients, with the patients having the COVID-19 as well as the breast cancer there. Next. So the cranial nerve involvement in the COVID-19 shows that the complaint due to the involvement of the different cranial nerves are also observed in a significant number of the patients, determining the distribution of these cranial nerve impairments according to age, gender, complaints, and the revealing the prevalence in the infected people can provide guidance in combat with against this disease. Next. So symptoms of the involvement of the different cranial nerves apart from the taste and smell disorders reported, symptoms such as smells, taste, visions, and sudden hearing loss, vertigo, swelling of disorders, hoarseness, eye symptoms, and the facial hyposthesia completely disappear within the first month of the infection. Taste and smell disorders rarely last more than 1 month, and cranial nerve symptoms regress with the current COVID-19 treated protocols. And the dominant effect of the cranial nerve involvement is on sensory dysfunctions compared to the motor function, suggesting that virus causes more sensory dysfunction rather to be on the motor dysfunctions. Next. So the peripheral neuropathy, which are here depicted in the picture here, the numbness, especially in the arms and the legs, stabbing pains on in the back, and the burning sensations in the on the extremities, particularly on the lower sides, and sensitivity to the touch is decreased particularly on the lateral side of the in median side of the calf as well as thigh. The coordination difficulty is also there sometimes. Initially, that definitely patients are do not having the particular coordinations with the particular reflexes there. So the coordination is definitely abnormality is definitely difficult initially, and later on this comes no more nearly come completely. Muscle weakness is also there, and bladder bowel dysfunction is also there. Yesterday, I have seen a patient who was suffered from the COVID. Thanks God, they are recovered through my treatments and the grace of the gods. Patient complaining having that their bowel dysfunctions. So I could not pass stool properly as I before the COVID. Also, I cannot pass urine properly. I have difficulty in urinations too. So these complaints are complaining. I assure them I have given some medications and definitely it will recover. So I assure them. So these are the common findings our facing our day-to-day clinical practices. Next. So what's the management of the neuropathy? Is very simply we are particularly we are knowing all that, and what is very important also, diet glucose. If the patient is having glucose, and sometimes the patient has taken the steroids, so the patient is taking a steroid, there is high chances of increasing the blood glucose levels. So we have to focus on the controlling the diet glucose and reverse the challenge changes, but only if the neuropathy and the diabetes is recent onset. So, and that's tricyclic antidepressants. We know that TCA are very well in controlling the peripheral neuropathies, like the amitriptylines and the nortriptylines are very good in controlling the peripheral neuropathy. We are usually prescribing the medicine when our practicing early before the COVID-19. We are giving these medications. TCAs are there. Antidepressants also, like the gabapentin. We are nearly gabapentin, pregabalin, nortriptyline combination. We are using here. The first line treatment of the painful neuropathy is there. Second is a methacholamine. As you know that methacholamine exerts the neuroprotective effects and regenerate the myelin sheaths. So we are prescribing the methacholamine 15 milligrams. It is better to give 1500 milligrams in TDS. 500 milligrams TDS is the beneficial effect. Benfotiamine also is there, and some other zinc, cobalt. These are the very good in the peripheral neuropathy treatments. So next. So conclusion is here. The global pandemic of the corona disease virus disease has challenged the healthcare systems, and many questions remain with the regard to our understanding the virus, its sequels, and long-term outcomes. The mechanism of peripheral nerve injury in patients with the COVID-19 may be multifactorial, including the complication of the systemic disease and direct neuroinvasions and autoimmune symptoms and response. The patient with the COVID-19 are at high risk of peripheral nerve injuries. Patients potentially due to comorbidities such as diabetes, obesity, older age, or plausibly secondary to the virus-induced state of the hyperinflammations. The nervous system lesions due to COVID-19 are life-threatening, and their consequences can have a huge negative impact on the person's life, especially pre-morbid, morbidly burdens, and especially COVID-19 severity and the prospect of its frequent adverse outcomes call for the expediency of the in-depth study of the clinical manifestation of the disease, improvement of the methods of the prevention, early diagnosis for neurological complication, as well as their rational pathogenic treatments. Next. Oh, thank you. Oh, thank you very much.
Now the session is open for question answer, sir.
Yeah.
You
Any question is there?
Yes, sir. We already got some questions.
Right.
There are patients with severe nerve damage after COVID-19 treatment. So what is the duration of full recovery of these patients?
It depends on the how much nerve is damaged. It usually, if there is a mild to moderate, it takes 1 to 2 months to recover by intensive treatment, like the medication which I have already described in the slides, as well as the physiotherapy is also recommended here. So it will take 2 to 3 months to recover. If there is a severe damage, so it is very difficult, outcome is very difficult, but of mild to moderate, recovery is very high.
Okay. So another question is there, is post-COVID weakness is also there in some patients. So is it a sign of nerve damage or neuropathy? And what could be the treatment?
Actually, the term weakness, the term is very vague actually. Where is the weakness? It is the muscular weakness, it is a neurological weakness, or some metabolic weakness. First of all, we have to evaluate what type of weakness. If there is a muscle weakness, if there's a nerve weakness, we definitely focused over that. The patient might be having the peripheral nerve injuries, and we currently diagnose that and treat them. If there is a metabolic and other weakness, like sugar is not controlled, blood pressure is not controlled, other saturation is not well enough. So we have to focus there, and we have to treat there accordingly, and definitely patients get benefited from the treatment by the consult physicians.
Another question is there, sir. Patients are complaining about low back pain also. So what would be the line of treatment for those kind of patient? And is it because of nerve injury?
It might be. It might be because if the patient is having low back pain, it might be possible that the patients may have a nerve injury because L3, L4 nerve is there, and it might be there is a low back muscle pain associated with that. It might be possible that the patient is admitted in the long admission, having hospitalized for the long durations. So it may cause the back pains. It associated. There is a chances of bone abnormalities also there. So we have to take initiatives according to the MRI, ultrasonography, these kinds of modality used there, and a simple X-ray is also very beneficial initially there. So we focus that it might be maybe due to a nerve injury, due to a muscular injury, maybe the bone, other reasons also be there. But back pain is also associated with the peripheral nerve injury is also there. We have to take account it.
So one question is coming from one doctor from Patna. Patient is complaining about facial pain and headache post COVID-19. So how to go ahead with diagnosis and treatment?
Definitely, we have discussed one thing is in the slides previous year. There is a muscular weakness of the facial muscular weakness there. There is a facial muscle involvement, might be a facial involvement because the facial involvements. So vagus nerve is there, facial nerve is there. So definitely, and there's also headache. I have already said I have described a patient case where my friends neurophysicians there, he complained that patient post-COVID having multiple vascular ischemia. So definitely, if the patient is having headache, definitely go for the CT scan. CT scan evaluate where if they have any patients having a stroke or not, and like a mild stroke. So CT scan is very important. Facial nerve injury is there, so go for the some exercises and physiotherapy there, and the like the medications, methylcobalamin, nortriptyline, and as well as the pregabalin should be initiated immediately.
So one question is coming from Muzaffarpur. Does using steroid cause nerve damage?
Definitely, steroid was very, no doubt, definitely, I'm very right. The irrelevant use, unjudicious use, and the use by the such kind of the people who are not having the knowledge of steroid, when to start and when to taper, when to abolish the treatment. Definitely they cause the damage, because they cause the damage. Sometimes initially, it is no doubt if the patient is having the edema, nerve edema, and these things, the steroid is beneficial there. But injudicious use of the steroid causes the nerve damage, and this is seen in the patients of the COVID patients.
Right. What are the supplements ideal for neuropathy? This question is coming from Patna.
Just I have shown in the slides there, nortriptyline is there, if the pain is subsidy has there, GABA neuron, TCA, GABA neuron, gabapentin, and the pregabalins there, benfotiamines, methylcobalamines. These are the drugs we are using during our treatments. We are affected, we are benefited to the patients.
Right. So I think that's all from question answer round. Right, sir.
Thank you very much.
So it was really enlightening session for all of us, and on behalf of Corona Remedies, I would really thank you for being a speaker and for giving us time from your busy schedule and giving some knowledge to us. That is also a very enlightening session for all of us. So I would also like to give you a special thanks to all the enthusiastic participants who has questions very very useful way. They have they have also increased knowledge for all of us. So thank you so much to all the participants, and thank you so much Dr. Hasnain Kaisar for joining us.
Thank you very much. Thank you very much.